Welcome, folks. We're going to give a little time for people to filter in, but glad to see you all here. I think it'll be a great conversation today. Oops, Shannon, your screen went away.
I had a feeling I pushed something.
There it is.
There, now it's back.
All right. So, as we're giving folks a minute to pop in, feel free to introduce yourself in the chat. You can use that as a place to communicate throughout the session. And let me just make sure that the settings are okay so everybody can use the chat. Yes. Okay. So yeah, feel free to use the chat to introduce yourself and share thoughts as we're going through. This is certainly meant to be an opportunity for you to join the conversation as well. So we welcome you to introduce yourselves in the chat and say what you're thinking, or say, oh my gosh, we've had the same thing, or what about this? So just keep communicating that way with us. And then, so essentially, and I always forget to introduce myself. I'm Gabi, and I I am mom to Elliot, who is here on the right-hand side of your screen, who is 12 and has SCN8A DEE. I am the co-founder of Deep Connections and the executive director, and work closely with Shannon, who is our amazing staff person for Deep. And she's going to kind of really run us through everything today. And a few housekeeping things are that one, if you are joining the webinar as a panelist, not as panelist, as a attendee, you are off camera and you're muted. So don't worry if you're trying to multitask, which I know we all always are. That's the essence of our lives. So don't worry about that at all. And then, as I mentioned, feel free to use the chat or the Q&A at the bottom of your screen at the panel to ask questions. You're going to meet our parent experts first, Dami and Mary, and then Dr. Shylon is going to walk us through some outline of what palliative care is and how it works in their program at Cook Children's. And then we're going to have an open panel where all of us will come back and we'll chat, and we'd love to hear from you, get your questions, get your experiences, and we'll take it from there. So thank you so much for being with us, and I'm going to hand it over to you, Shannon.
Awesome. Should I keep sharing? I feel a little because I can't see anyone.
Oh, you can take it down.
But
Yeah.
okay. I know we're gonna Dr. Trilon. Hi guys. I felt like I couldn't see anyone. Um, so yeah, I'd love to introduce Mary and Dami. How about Dami, you go first. You look ready. You can tell us a little bit about your sweet kiddo and how you guys utilize palliative care.
Yeah, hi. My daughter is Marley. She's 6 years old. She was a 24-weeker. So she had a grade 4 brain bleed, which led to a list of other diagnoses following that. She has hydrocephalus, cerebral palsy. She has short gut. She is YouTube fed. She has epilepsy. Lately, this past year has been probably the hardest of her life. We've spent more time in the hospital than at home in this past year. Our palliative care is such a huge part of our journey. They've been involved since birth, and we are fortunate to have the same palliative doctor her entire life so far. So they've gotten to see her grow, and they've gotten to see her have good moments, hard moments. They've been a huge support for Marley, but also me as her mom. They've helped us with sleep management, pain management. Um, Most recent, they have helped us like navigate some very difficult conversations while Marley was in the ICU. Um, there were times where I got worried and I was able to just give them a call any time of the day, even if it was 3 o'clock in the morning, somebody would answer. And either they would calm me down or just walk me through the decision making in those moments. Um, Recently, I'm really excited. I actually this week I'm gonna start EDMR therapy. So I'm really excited about that. I've heard great things, and I'm just so happy that we get to do that with them. That's probably not something that I would have access to without palliative care right now. So that's really going to be helpful.
That's amazing. Well, thank you
Yeah.
for sharing. And
Yeah, thank you.
Mary, tell us about Hannah.
All right. Yeah, Hannah is 8, almost 9. She'll be 9 later this month. Hannah has a collagen deficiency, COL4A1 collagen deficiency, which caused stroke, an in utero stroke. She's actually a full term, like 42 weeker baby. She did not want to be born. And we didn't actually know there was anything extra going on for a couple of months. So that led us down into all the things, and we didn't get connected with palliative care until she was, I don't know, maybe 2 or 3. Maybe it was more like 2, but we have a weekly nurse visits. That's like one of the biggest things for us, and we are so lucky because our nurse where we live is a little bit rural, and our nurse actually lives like 2 minutes from us. We're very spoiled. So she comes over, anytime, basically anytime we need her to. Or there's always somebody on. Um, at minimum weekly nurse visits, but they'll do things even like go visit her at school. The school she goes to has a couple of kiddos in their program. So if she's in a really good spot, they'll even go visit her at school, which, kind of just relieves some stress on knowing that she's getting checked on. But, we get prescriptions delivered to our house. That is huge, huge, huge for us. And they've always been able to get about, I don't know, 95% of our prescriptions. Once in a while, there's something weird we have to get someplace else. What else? They have some therapy available, like physical therapy, OT stuff, but it's pretty limited. I mean, it's limited where we live no matter what. So I don't think that they're any way deficient. It's just life. And kind of unique to us is we live about 3.5, 4 hours from our main hospital system. But they're actually kind of a local program. So they're with a smaller hospital. They have a big branch for adults, but at this smaller pediatric unit, which is, I don't know, 4 or 5 nurses and one doctor. So everyone knows Hannah really, really well. There's definitely some benefits to that. And so no matter who's on, everyone's got a really good idea. We've spent the last 2 years really trying to make decisions and figure out the best road for Hannah. Right now, she's TPN dependent and probably will be for her whole life. And they don't manage her TPN, but it's the same hospital system. So when we get her prescriptions delivered, they also deliver her TPN, which is 10 out of 10. And then they helped us kind of decide that was the road that we were going to go down last year after a couple of really hard years of decline and Hannah just hating all food ever. Um, and yeah, I mean, I don't know how I would do it without them. People ask like, well, when's the last time you talked to your pediatrician? And we love our pediatrician and he's 1,000% amazing. But I'm like, oh, I don't know. I just, every once in a while we text him, because our palliative care team handles so much of Hannah's care. So I'm just so thankful for them.
That's amazing. Well, now I'm going to introduce our clinician that's with us today. And I have a personal connection because he was our palliative care doctor with Zoe the last year and a half of her life, which I slightly regret it only being that long. We should have had them on our team the whole time. So Dr. Chylon, he works at Cook Children's, and which is right down the street from our house, unlike Mary. We're 5 minutes away. But I'm biased, but I think he's amazing. But I'm so glad he's here today and agreed to come to share everything about palliative care and how that team can really help your child's quality of life and your own quality of life too. So Dr. Chalan, you can take over.
Thank you so much for your kind words, Shannon. It was a pleasure taking care of you and Zoe for sure.
Yeah.
I am going to share my screen and go through a presentation. But again, I'm Dr. Chalan, one of the palliative care doctors, one of the 4 doctors actually at our hospital. And you may see very different programs. There may be only 1 doctor, there may be 10 doctors, but most of the times there's a doctor or a nurse practitioner who will be working with you through the palliative care team. All right. Okay. The presentation looks good.
Yep, looks great.
Perfect. So what is this palliative care that we have been talking about? When I first meet with the parents, they either say they have never heard of it, but they also may have heard of it, but they pretend like they haven't because it is generally associated with hospice care, unfortunately, and people are very scared that and worried that if their child might be dying. So I'm going to try to make it a little more understandable for everyone. Our agenda is we are going to ask some questions and try to find answers together and see if any of that resonates to your lives as well. And after that, open up to questions and answers with our panelists. So again, many people, when they hear about palliative care, this is what they see. It's many different words, many different things that comes to mind, and generally, it's a challenging word to hear. I'm hoping that by the end of the presentation, we may turn it to this. When you hear palliative care, it's more you have a better idea, and it's more loving, and you feel the support behind the palliative care. So let's go ahead and talk about what palliative care is. Of course, American Academy of Pediatrics have policies around that, and they say this is the field of the medical expertise that helps improve quality of life, reduce the stress, help with the symptoms, and help with the families, not only the child, but the families too, in the setting of serious or life-threatening conditions. It is an interprofessional team. There you may see many different team members, and we'll talk about that in a little bit. It is actually appropriate at any stage of serious illness. It doesn't have to be end of life, as many people think of when they hear about palliative care. It can be offered in all care settings, and it was a great experience. I loved hearing about all three moms here. I don't know, Gabby, how your setting is, but they have different settings. Sometimes it is provided at home, so we call them community palliative care programs or community-based palliative care programs. Actually, some states offer that under the state, and they sponsor those programs. Sometimes it is purely hospital-based. Some programs have both inpatient and outpatient. They see patients both when they are admitted, meaning inpatient. They also have outpatient clinics as well to be able to do clinic visits with their patients. And sometimes there are multiple palliative care teams involved, and they communicate with each other, and they try to make sure all the needs for this child and the family is covered. And it is not only about what we think is the best for your child. It is focused about what is most important for you guys, based on your values and your wishes. And the goal is to add life to child's years, not simply add years to child's life. So our goal might be, the family's goal might be adding more years to life, but our goal is, while we are doing that, also adding life into those years as well. When I present palliative care to the families that I meet with, sometimes again we hear that from the primary teams we talked about palliative care and the family does not want that. It is extremely rare when I present what palliative care is to a family and the family doesn't want that to be involved. Actually, we generally get like, where have you been, guys? Where have you guys been? I wish you were involved right at the birth. I wish you were involved 3 years ago when we were trying to make decisions about the next big thing. But what I tell them is palliative care is a program that provides an extra layer of support. We are different clinicians, different specialists from different disciplines. We try to make sure the family, especially in the beginning of the diagnosis, when they hear a lot of new information, we try to make sure all that new information is clear for them and they understand that very well. We want to make sure while they are hearing all the right information in a clear way, we want to make sure the family's voice also is heard by the rest of the medical team as well. We try to get to know the families as best as possible. So when there are any decisions to be made about the care, we try to understand their hopes, goals, values, and we try to help them making decisions based on their own values, not again what we think the best for the child and the family. We are experts in symptom control, and those symptoms might be a quite different area of it, but most common symptom is pain. However, we'll talk about what other symptoms we might see and we might be helpful with as well. And yes, we also sometimes do help at the end of life as well. This is a part of our expertise as well. However, I would say this is a pretty small part of what we do day to day. So hopefully, again, we ended up helping Zoe with that. We ended up going through with that with Zoe. And again, three of our other panelists still have their child alive and they talk very highly about palliative care. And sometimes we are involved in the child's care from until they are born to their adults or they leave the children's hospital. So it is a lifelong journey and we want to walk that with you guys. And what palliative care is it is also young. So first freestanding pediatric palliative care center was built in 2004, and it was recognized as a subspecialty only in 2008. So it's not even 20 years in the United States. That's probably why not everybody has access to palliative care services, or every team that they meet are doing something somewhat different. However, again, all those programs work in the mindset of providing that extra layer of support. Actually, the word palliative comes from the Latin word palliare, which means cloak. Again, that extra layer that you put on top of all your garments. Who are the team members? So generally, you might see physicians, nurses, advanced care practitioners, social workers, and spiritual care counselors and child life specialists are almost always involved as well. They may be involved as a part of the primary team, or they may be involved providing the support from their own groups. However, again, they're an extremely important part of pediatric palliative care because, again, it is not only about the child, it's also about the siblings, the parents, and the greater community. But as you may see, I'm not going to go through every single one of them. As you may see, there's a wide array of people who are involved. In our program, we have physicians, nurse practitioners, clinical therapists who actually support the families, not the child directly, but support the parents. We have social worker and we have nurses as well on our team. But as I said, you may have even occupational therapist or physical therapist or pharmacist on the team. I was just telling, if you meet one pediatric palliative care team, you meet one pediatric palliative care team. You may actually end up seeing them in different shapes and forms. But as I said, it is always within the goal of providing that extra layer of support. How do we help? Again, symptom management is one of our expertise, and there might be many symptoms that you might have experienced with your child. And pain is one of the most common symptoms, nausea, vomiting, constipation, especially in the patient group who are living with DEE. I know that is a big problem, and sleep disturbances, agitation, anxiety, self-harming behavior, and many other things that I didn't even put in here on my slide. We also so there is a very strong evidence from different studies that actually shows that if pediatric palliative care team was involved in the child's care, the symptoms have decreased, parents and patients' quality of life has significantly increased, and specialized palliative care is associated with improved quality of life and reduced symptom burden. And whenever we compare children who received palliative care and who didn't, the ones who had pediatric palliative care were found to have increased quality of life as well. And there are also studies, unfortunately, the clinicians are worse than the parents to assess the symptoms and realize that there is a symptom that's bothersome to the child. So it always requires patients' advocacy and experts on the team who can assess and treat those symptoms that haven't been able to control by the other subspecialists. Communication is a huge part of what we do. As I said, we want to make sure you hear the rest of the team and the rest of the team hears you as well. And we want to make sure you are always in the center of the care, because unfortunately, most of the times I hear that quite a lot from families who are living with children with complex chronic conditions. You come to the emergency room, you say something specific about your child. Every other child is unique. You say, okay, my child needs this medication at this time. If you don't get it, forget it. And unfortunately, sometimes those requests are dismissed, and 10 days later, and a lot of different medications and a lot of pain and suffering and friction between the family and the medical team later, the medical team decides to do what the mom said in the beginning, and everything looks much better within the next day or two. So again, communication is a huge barrier and a huge challenge that many families experience who are living with medically complex children. And unfortunately, not every provider feels very comfortable about it. This is not a quality. This is not something that we are born with. We actually go through training to be able to be good communicators. So when we look at the studies, again, families' priorities were honest and complete information. Many families tell me, okay, I don't like seeing you. You cause distress to me. I'm like, it's not something you do, but the name of palliative care is distressful to me. However, please let us know if there is something that we need to know about. If there is something serious going on, please let us know. We want to make sure the coordination is effective while these children are in PICU. The families also want to be able to express their emotions, and that is supported by the clinicians, and they want freedom to express their faith. So these are all under the expertise of pediatric palliative care. So it seems like we really can be helpful in those difficult situations. We also are experts about making those very painful communications many of the clinicians don't feel comfortable with, such as delivering bad news, discussing the limitations of the care, including the resuscitation status, and sometimes even talking with children who are dying and explaining them what is going on. And again, when this expertise is involved in the care, this helps the goals of care and the preferences are better heard, and the family is integrated in the decision making, and also it gives not only the family but the entire team a big picture perspective, so we don't just get focused on one problem or one organ system and be completely be missing the picture. We also try to help with care coordination and social support. You can also involve emotional or spiritual support in those as well. As Mary shared, sometimes the palliative care teams go to school and talk with the school staff or even the patient's friends at school and explain what are the challenges that they are going through, or how to help with that child's care and make sure they get the education that they need as well. Also, it was shown that support of the family can be optimized by palliative care teams working with the primary care teams. So it is an extremely important part of ongoing support for the family. And also continuity is another very big thing in this day and age, especially in the big hospitals. There is such a big turnover of the providers, and palliative care team can be the stone that's sitting there and making sure all the people who are being involved or rotating in your child's care, palliative care team can be the people who are coordinating all of that and seeing the big picture while different people are focusing in different problems. And grief and bereavement is another part of what palliative care helps with. Every single family grieves with loss of normalcy, grieves with serious illness. Grief does not only happen if a parent's child dies. It starts with the diagnosis of the serious illness, and it goes through the care of the family. And also, families appreciate the clinicians being supportive and present when they're grieving, and they are good listeners. And also, of course, if a child dies, we are also there to continue supporting the families through their bereavement journey, which can be very unique and different for every single family. The question is, are we there yet? Because many times when I talk with the providers, what I hear is we aren't there yet. And again, when I end up talking with the families, they say, where have you been the last 3 years? So let's talk about when is a pediatric palliative care consultation can be helpful. So when we have pain or other symptoms that do not respond to standard measures, if we have decreased quality of life in the setting of serious illness, if there is need for support for a seriously ill child's family, we are there if there is help needed for clarifications of goals and limits of therapy, for medical decision making, for end-of-life care and bereavement as well. And there is an organization called Center for Advanced Palliative Care, and one of the suggestions they published suggestions when palliative care should be involved. Definitely, if there are conflicts regarding use of medical nutrition or hydration in cognitively impaired or seriously ill or dying child, but also any new diagnosis of life-limiting or life-threatening disease, 3 or more hospitalizations within 6 months, difficult pain or symptom management, patient, family, or physician uncertainty, regarding the prognosis, family with limited social supplies, orders around allowing natural death or DNR, complex care coordination, prolonged hospitalizations for more than 3 weeks, and need for hospice resource support. So when I say those, I can only imagine many families who are living with a child with DEE is probably in one of those categories who can actually benefit significantly from pediatric palliative care involvement. So why is it important? Again, as I said, there are many things that hits if palliative care should be involved, but why is it important specifically for children with DEE? So when we look at the children with complex chronic conditions, many children living with DEE, like Mary was just saying, like it was one thing, and then, sorry, Demi was saying it was a brain bleed, and then it opened a whole area of different complexities affecting multiple systems. And whenever we see that chronic complex diagnosis is related with brain, because the brain is the center and the computer that's controlling the rest of the body, it is almost always there are other systems that are affected as well. So when we look at this chart, which is fairly old, they looked at the children who has only one chronic condition, and they looked at the children who has more than one chronic condition. And as you see, over years, the hospitalizations of children with more than one chronic conditions has increased significantly. But this only goes until 2005. Let's look at this. So this is more recently published and looks at a lot more current data. I want you to focus on the blue lines. And actually on the left side, when we look at the line, the hospitalization numbers have decreased over years for children living with medical complexities. However, the days spent in the hospital has increased slightly over the years. And I think more importantly, again, looking at the blue lines, when we look at the percentage of the hospitalizations to children's hospitals, over 30%, almost 60% of all these hospitalizations are children with medical complexities, children who already deal with previous medical conditions. And percent of hospital days spent, more than 70%, almost 80% of the total hospital days spent were spent by children with medical complexities. So many children with DEEs are spending a lot of time in the hospital, and palliative care team can be the support that they need during those hospitalizations, and hopefully preventing some of those hospitalizations as well. And also, many children with DEEs have a unique life trajectory, if you would. The blue line represents a relatively healthy person, generally born with a very high, you can say, wellness, health, or quality of life. They are born with very high wellness, and over time, generally, it goes pretty well for the first 30, 40 years of life, and then we start having some medical complications. Our knees start hurting, our backs start hurting, and diabetes, hypertension. And overall, over time, our wellness decreases. And when it reaches zero, that means that we die. Children living with medical complexities, especially children who are born with certain genetic conditions that are affecting their central nervous system, their brain, unfortunately, their wellness starts much lower than that. Sometimes they make a big decline in the first few weeks to months. Sometimes it's a steady decline over time, not very fast, but certainly steady. It's not fast enough that when you compare week to week, you may not realize any difference. But many families say when they compare years or 3-year increments, they realize that even if their child's quality of life is similar to where it was, they realize that there is always new medications, different methods of feeding, new technology dependence, and more hospitalizations in between. And you will see some decline on those wellnesses, and those represent whenever the child is sick. Sometimes it's an acute sickness, a viral illness. They get to the hospital, their wellness decreases quite a bit, but then almost always they recover, and unfortunately almost never to where they have been. Slightly lower maybe, but they always have something new added to their care. And then there might be another decline, and for this decline, the recovery phase might be much longer. But again, unfortunately, if you take a look at it, it is not where it was before. It's slightly lower than where their quality of life was. And this keeps happening until, unfortunately, one of those events is the last. So they generally have a shortened life compared to otherwise previously healthy individuals. So when do we involve this pediatric palliative care? It used to be like this. Before, we always do life-prolonging care. And then when we don't have anything else to offer to prolong the child's life, they would say, okay, palliative care and hospice comes in, and we let the patient go home or stay in the hospital for end-of-life care. And this is actually what many families think of when they hear about palliative care. And this is unfortunately how still things are in the adult world. However, when we look at the newer trajectory, we get palliative care involved on day 0 at the very beginning of the journey, and palliative care is there. And over time, as the life-prolonging options get less and less, palliative care involvement might be increasing. However, I still don't find this very accurate either, because sometimes life-prolonging care is involved, but it also has a lot of side effects. So palliative care team involvement may go up with that. This, I think, represents a little bit more how things are in nowadays. So palliative care is involved very early. Disease modifying or curative care is there, and over time it fluctuates. Sometimes it goes up or down, and closer to end of life, hospice support is there, and both palliative care and hospice supports continue even after the death of a child. And the good thing about pediatric palliative care is you don't have to choose one of those doors. It actually is a double door, and it can be open at the same time for the children living with serious illnesses. So we talked about how great it is, like how we can be helpful and all of that. Why don't we have every single child pediatric palliative care at the diagnosis of their medical at the end of their medical journey? It can be provider related. Many providers unfortunately have limited knowledge or training about pediatric palliative care. They feel like, okay, we still have curative or life prolonging options that we can offer to this family, because again, the thought is palliative care is only there for end of life. They fear of presenting it to the family because they may feel like they are taking away hope from the family. And again, pediatric palliative care is all about hope, and making sure those hopes are supported as well as possible by the entire palliative care team. And unfortunately, there is lack of clear protocols or leadership about this. And unfortunately, again, there isn't always good support, good system-wide support for pediatric palliative care. So some of the families might not even have access to pediatric palliative care close to where they live. And sometimes those barriers can be family related as well. Family may not have yet acknowledged the prognosis of the child, which is a very normal human reaction to moments of challenges, and it may take for them to recognize that and recognize that they may use some extra layer of support. And also, they're afraid that if palliative care is involved, it will hasten the child's death, or they are giving up on their child. And again, it is all about your values, your hopes, your goals, and your fears. Of course, talking about palliative care, I need to talk about hospice a little bit as well, because I kept saying hospice and hospice. For detailed, I would say it's just a few, I have just a few slides on that, but I love the webinar that is recorded in the Deep Connections website, which is a more comprehensive review of hospice care. But palliative end of life, as I said, is a smaller part of what we do in our day-to-day work, and hospice is a more specialized part of end of life as well. And they aim to support the child wherever they call home. Sometimes it is a long-term care facility. Most of the times it's the home of the child, and they try to make sure that end of life is or last months of life is as comfortable as possible. However, we have many children, many patients that we refer to hospice, and they continued living under hospice support for many years. Many times they get discharged from hospice because their clinical course has stabilized and they are doing pretty well and they don't need the hospice support. And then they can be re-enrolled if there is a serious illness going on and their trajectory changes. And after they stabilize again, they get discharged again. So it's not necessarily a label that you put on a patient. It is all about if the patient can benefit from the support or not. It is, again, a particular form of palliative care for patients whose life expectancy is 6 months or not, or less. However, as I said, especially when it comes to children, we are very bad about knowing what that means, knowing what those signs mean. Sometimes it's a part of acute illness and they recover. Sometimes we make all those difficult conversations with the families, and the child doesn't care about it and goes home and continues where they have left off from their quality of life. And it is actually an insurance benefit. So it is all about if this child is eligible for that benefit or not. And if they have an acute phase of their illness, they can very well be enrolled with hospice. And as long as there is some decline, and we almost always see some decline with the children with medical complexities, they can continue to benefit from that extra resource. And those teams have a bundle of services involved. They have nursing that comes and checks on the patients and the families regularly. It depends on how often, depends on where the patient is. They always has a physician involved. They have social and spiritual services. They deliver medications and durable medical equipment to the child's home. And there is a range of diagnostic tests and therapeutic interventions that they can offer, especially related to the child's comfort. The advantages of pediatric hospice is concurrent care. So for adult hospice, you need to give away all the disease-directed treatments. However, for pediatric hospice, anyone under 21 years of age can get hospice and their regular care at the same time, so they do not have to give up anything at all. And the challenges, unfortunately, is many hospice programs don't have a pediatric specific program, and many adult providers, including the physicians and nurses, does not feel very comfortable taking care of those kiddos because they are used to taking care of adults. And thankfully, because and this is because there aren't too many children who are living with many life-limiting conditions. However, I know that like the amount of hospices that provides the support or the number of palliative care programs keep increasing significantly in the United States, and I hope there is one close to you as well, and they can be supportive to you during your long journey. With this note, I'm going to end my presentation, and we can open it up for questions and answers or any feedback. Again, this may look different than what you guys experience, so I would love any feedback from the team.
Well, thank you so much, Dr. Chilan. That was amazing. Covered a lot of ground there. I want to start with Dami and Mary. Did you guys have any reaction, or did you feel like there was anything you wanted to talk about in response to what you heard from Dr. Chilan?
I don't have anything specific at the moment. I do think it was a very like informational video or presentation for the parents. I've come across like a lot of families who just don't quite understand what palliative care, and like you said, they're so afraid of the word. And I wish that we could give that presentation to every parent.
That's what we're doing
Um,
now, hopefully.
yes, yes, yes. I hope all the families that need to see that. Um, because I mean, I had to learn for myself. Like, I had to learn to trust the palliative doctor because I was the same way. Like, I was just like, whoa, 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 why are you here? So no, you seem incredible, like Shannon said.
Thank you.
Yeah.
Yeah,
Um,
I would agree. I feel like I've given like a little mini version of that presentation to like other parents before. Um, because it is an overwhelming concept, and like our program is directly under an adult hospice program, so like things just show up on paperwork that is maybe like not what like that would be more scary or more overwhelming. I think we were lucky because it came to us in an outpatient setting. I'm sure it's far more overwhelming if it comes to you in an inpatient setting.
Mhm.
So yeah, I was just thinking actually that I should just send this over to my our nurses because they, you know, they
Hmm.
maybe make their lives a little, because I think sometimes our palliative care nurses are actually the ones that take the brunt of some of that. I mean, our doctors are wonderful, of course, but you know, I think the nurses are the ones a lot of the time on the phone with the, you know, with the parents, you know, at 3 a.m.
Mhm.
Unless, you know, the doctor really needs to be on the phone. So yeah, thank you so much. That's so good.
yeah, it was super informative. I guess for me, I didn't realize pediatric palliative care is so young still, that it's only been around not even 20 years,
Exactly.
Yeah,
which
I didn't know that
probably,
either.
yeah, which explains a lot of the misconceptions that are still out
Hmm.
there. And um, yeah, so it's exciting that hopefully we're just bringing awareness, and we can
Hmm.
just send this video to all our friends.
Yep.
We do have a couple questions. I have one that says, how do you determine if palliative care is a good option if your kiddo's overall stable? Her daughter specifically has HIE, CP, and epilepsy are her big diagnoses, but she's stable. Which I
Absolutely.
guess, yeah, you
So
kind of would.
I think the best time to involve palliative care is when things are stable,
Mhm.
because
Hmm.
Yeah.
again, it's not only about the current state. Like even if you may need any support at that particular time frame, getting to know your palliative care team, if or when things change, or all of a sudden a simple viral infection can be very challenging to those children. All of a sudden there is a viral infection and your child is in the pediatric ICU. It feels a lot more scary for palliative care to come then to meet with you. And unfortunately, that's
Hmm.
sometimes the only opportunity we get to meet with those families and meet with those children. So it may look scarier. However, if you get to know the team ahead of time, they may be able to help with you get to understand your values. So whenever you are in the hospital, whenever your child is sick, they can provide that support the way you want it to be. I have patients that I sometimes see once a year. Sometimes I schedule them 2 years out. If everything is stable, that's perfect. And I tell
Hmm.
them if you are admitted to hospital or if things change significantly, please give us a call and I'll see your child much sooner. So again, I think stable time is a perfect time to get to meet with the palliative care team.
Yeah, I think I had a follow-up question, I guess, to that I just came up with. And I think with Zoe, we saw palliative care when she was much younger, when we realized, oh, there's something big happening in her life. Like there was a genetic condition. But who, I think neurology referred us, but I don't know, like if this mom, who would she go to? Like her pediatrician and say, can you refer me to?
That's a great question. I think I would say if their hospital or their setting, if we are looking for hospital-based palliative care, uh, it can definitely be the pediatrician or the neurologist. It sounds like neurologist is involved quite a bit or needs to be involved quite a bit. Or if it is a community-based program, actually families can self-refer themselves as well. It doesn't have to go through a provider either.
Mary, is yours community based?
Yeah, ours is through a hospital system, but they don't have a pediatric unit. So I think that would be considered community based. I think we got referred by our pediatrician. It also could have gone through, we're in California, so we have what's called regional center. I
Mhm.
think the social worker there could have referred us.
Okay.
Um, I think either of those things would be great. And I definitely want to echo that I would do it when you're not in crisis because it
Hmm.
builds a level of trust. And then having those difficult conversations. I mean, we've had the like, DNR conversations and what does that look like and what interventions are we keeping on the table? What are we taking off the table? And having those conversations when things are stable is just, I think, infinitely easier. Not easy, but um, easier to wrap your head around than doing it in a moment of crisis and stress. So yeah, we're lucky to have a community-based program. We actually don't. There's an inpatient program, but that's not the same for us. But they are very good. I mean, I've never met a palliative care team that's not willing to talk to another palliative care team. I mean, it's just a very collaborative and like
Hmm.
ego-free subspecialty, I think. So which is really important. So
Can I add something there? Or just a quick question is, I mean, if somebody is in an area, they're at a hospital that doesn't have a palliative care team, they've never been referred, someone in the chat was saying, I've never even heard of this. I mean, we have complex kids all over the place that whose families don't know about these programs. And if someone watches this and says, oh my gosh, this is what we need somebody to help us manage all of these subspecialists, all of this complex care, right? Who can they go to and ask? So you mentioned a neurologist or a primary caregiver,
Mhm.
but and I guess people can also just try to look up, is there a website where people can go to find palliative care teams in their area?
Certainly. They can definitely look up things. National Project for Hospice and Palliative Care is one of the resources. They try to update their list, but even a um, Google search, I would say, like pediatric palliative care programs around me, would really be beneficial. And if they don't have anything local, again, the main hospital they go with to see most of those subspecialists um, should almost certainly have a pediatric palliative care program. And they may not be offering outpatient services. However, they likely know the services in your area that you can be connected with.
Mhm. Or social, I'm sure social workers are probably a good resource too, or yeah.
Absolutely.
Mm.
our
So,
hospital system also has complex care pediatricians, which isn't the same, but can do some of those outpatient type things that palliative care would do as well. So you might also ask if they have any complex care pediatricians, because those really help to coordinate between subspecialties, which is a huge mental load
exactly,
for complex kiddos.
absolutely. Demi, I
Yeah.
think there's, yeah, go ahead.
I've always wondered, even in like the medical world, within like physicians and medical school, if there is like a lack of education in palliative care.
Mhm.
And I say that because like I've met so many families out in my community that I'm just like, wow, I really think you could benefit from this. And then I've had experience, and one recently, I brought Marley to the ER. Wait, let me back up. We
Mm.
have morphine at home if needed. Typically, if I have to give morphine to Marley, I'm already going to plan to bring her to the ER.
Mhm.
And so in the middle of the night, I called Palliative and I said, "Hey, do you think I should give her the morphine?" He says, "Yep, go ahead, but probably head to the hospital." So by the time we got to the hospital, there was a resident in the ER that saw us first. And I told him, "Hey, at 3 a.m., I gave her morphine. That didn't seem to help." And his overall like demeanor changed. And he was like, "Morphine? Why did you give her morphine?" And I was like, "Well, she was in pain. Tylenol wasn't cutting it. And she doesn't deserve to continue to be in pain at home. So
Mhm.
that's what I brought her in." And then he continued to ask more questions like, "Oh, is she in hospice?" And I was like, "No, but we are in palliative care." "Oh, is she a DNR?"
Mhm.
"No, she's not." And so I felt like I had to educate the resident as
Exactly.
to like, hey, this is the palliative care route that my daughter is in. And I always wondered, like, is that why there's so many children that are not getting palliative care because of the lack of education in
Certainly.
the profession, I guess?
Exactly. So it may be funny, being a pediatric palliative care physician myself, I did not hear about pediatric palliative care until I was in third year, the last year of my,
Wow.
almost last year of my residency. And I did not really understand what palliative care is
Mm-hmm.
until I was like 3, 4 months into my fellowship. Like as I started learning palliative
Mm-hmm.
care, that's then say, okay, like this is what's about it. So
Mm-hmm.
it is unfortunately significantly, most of our providers significantly undereducated. Our nurses are
Mm-hmm.
a lot better than the physicians in terms of being palliative care friendly because almost every nursing school has it as a part of their curriculum, and
Mm.
it's getting much and much better um, for the physicians as well. However, if they didn't get that exposure yet in their training,
Mm-hmm.
it can be very unfortunate. And of course, it's not only about knowing about palliative care, it's also about knowing how to talk with your patients as well, right? Communication skills, as we were talking.
Yeah.
So, unfortunately, this is something that I can imagine how much you guys are being challenged with.
Mm-hmm.
And it is like I try to explain families, code status doesn't mean the care status, right? Like a patient,
Mm-hmm.
a family might choose not to go through resuscitation. However, this shouldn't change anything at all in their otherwise regular medical care. And I promise the families that that's not the case. At the same time, I want to make sure all of the rest of the medical team is aware of this as well. I find myself needing to educate them as well to make sure
Mm-hmm.
they don't put that they don't feel like do not resuscitate means do not treat.
Mhm.
Mm-hmm.
Mhm.
Mm-hmm.
We do have one other question in the chat, and she was asking, she's very involved with their team, their palliative care team, but dad prefers to be more minimal. How can we get dads to be more involved? And I would say this, I know you mentioned sibling support also. So I guess how can you guys help bring the whole family together? And especially with mom and dad, you want to be on the same page. With your child, with your decisions you're making for your child. And I think having everyone involved, obviously, that's going to help, you know.
We have families with various involvement in their children's care. Sometimes both parents have the luxury of working from home and they are almost equally involved in their child's care. Sometimes mom takes that roles most of the times moms end up taking that role, and sometimes dads they take that role to be the primary hands-on caregiver for their children. I also realized that even if I'm a father myself, there's a special connection between the moms and their children. If there are any dads listening to this, I want to apologize. Again, we love our kiddos a lot, and we have connection with kiddos as well. However, that special bond between the child and the mother is really different. And they actually um, have taught me they know how things are going about their child. No matter how many years I have been doing this job, I still trust mom's intuitions and thoughts about how their child is feeling more than my medical education because of that special connection with them. So this is something that we deal with quite often. Mom is the one who is with the child the entire day and night, that works out most of the day and comes in, maybe interacts with the child for an hour or two. Child looks happy because there's somebody who is interacting with them, and then the next day starts. They unfortunately don't have the chance to see the challenges that the patient and the mom goes through during the day. And what I found was most helpful was trying to get those fathers into the outpatient meetings as well. So I would ask mom for both parents or dad only to be the one who is joining the next visit, so we can talk about and understand what dad's goals, what dad's fears, what dad's hopes are as well, and try to open those conversations, try to create a safe space that talking about those things is okay and is very normal. And most of the times when I talk about those difficult things, it's not because I think the family has not thought about this at all. I know every single family, whether their child is medically complex or completely healthy, have some thoughts and fears about their children's well-being when they put their head in the on the pillow. However, many of those parents and families leave that inside them and never share this even with their closest one. I sometimes ask those questions to the family, especially when both parents are there, to normalize these conversations, to normalize those talks, so they can decide together. And I don't think it's fair for any single parent to make those decisions alone. It's a lot of burden, and I think it should be done as a team, as big of a team as possible.
Mm-hmm. And I think another resource that that I've encountered is really this methodology of shared decision making, right? Which is, that it's a discussion, and so maybe that's something that this parent can read a little bit more about, which may give them some insights about how to pull their partner in, because that's not always the easiest thing to do. I think some people cope very differently with this life, right? And some people that's just easier is to say, you handle it and I'm going to work and I'll do whatever. But so, and then just sharing how much it means to you to like have your partner in on that discussion, because it is a huge burden, as Dr. Charline was saying, to try to make those, and often it's life and death decisions, right? So, not leaving that heavy load on just one person. So, yeah.
Absolutely.
So we're just about at time here. Does anybody have anything final they want to say, or?
I'm gonna pull up our end screen.
Yeah.
While we're waiting.
Well, it's been a fantastic discussion. Thank you so much, Dami and Mary, for sharing your perspectives. We learn a lot from each of you about different methods of, finding this team, using this team, both in-home and inpatient, and having a palliative care team that's not connected to your primary care team. It can look so different. And Dr. Chalan, a beautiful job of outlining it all and what's the difference between complex care and and hospice care and palliative care and all of that. So I think it's been really, really helpful. So I'm really grateful for this conversation and look forward to following it up with Dr. Shailan and some other folks about how we continue to make these decisions complex and challenging decisions for our families.
Absolutely.
So, Shannon, I'm going to hand it over to you to say what's coming up.
Thanks again, everyone, for joining us. So our next scheduled thing we have is a deep chat. It's normally with me and Anne Thompson Heller, who's one of our board members, but she's also a DE mom. Her daughter Jordan's undiagnosed. Had this conversation last year all about how the holidays are a special time, but it's all often surrounded by grief in our world. Our kids don't, they already have all the toys they play with. They already,
Yeah.
going to family events is difficult, all the different things, all the different thoughts and feelings we have during the holidays. So that would be a really great time just to chat and support each other. And then some really exciting upcoming webinars are, which to be determined on dates. So make sure you join our mailing list there at that QR code to keep up to date. We're going to be speaking to a GI and in pulmonology about different ostomy. We call them different holes, different ostomies. And this was kind of a jumping off point for us, having palliative care first, and then moving forward and actually talking about some of these difficult decisions we make as parents. Like Mary was saying, her daughter's on TPN, so maybe she'll join us again for the GI part. We're excited to have Dr. Chilon's wife, who she's a pulmonologist. They're like a little power
Mhm.
couple over there at Children's. She's going to be joining us and talking about all the different decisions that can come when your child's struggling with respiratory issues. And then hopefully then we'll schedule something with GI talking about all the different, GJ, G-tube. There's so many different ostomy type situations that you can have that I'm still learning about. And then we're really excited. We're going to have a webinar soon about how to use AI to make caregiving easier. There's a mom who's doing some amazing things that I just met with recently, using ChatGPT to write,
Hmm.
write her insurance company, like
Yep.
ChatGPT writing them. It's really cool. All the stuff she's like setting calendar reminders for prescriptions, and like it's so cool what she's doing.
Wow.
Hopefully, we can do a how to use ChatGPT for that, just to make your life easier. So, yeah, I think that's it. Oh, and then if you'd love to take the survey and tell us how we did, I know we did amazing, but we'd love some constructive criticism, and of course join our mailing list. But that's all we have for today. This was great, really informative, and send this to all your friends so everyone knows about palliative care now. Yeah.
Yeah, thank you guys for including me. And it's been a pleasure meeting all of you.
Yes. Thank you, everyone, for coming.
Thank you for
Well,
inviting me too.
thanks,
Yeah.
everybody.
Thank you.
I put the link for the feedback in the chat. If people wouldn't mind taking 1 minute, we'd love to hear from you. And thank you, as always, for being part of our community.
Yeah, and we'll post the recording soon. So thanks, everyone.
Bye.
Bye.